Hello, students. Professor Zeeb here, and welcome to another session where we're going to talk about Chapter 7 in our textbook. So, Chapter 7 is all about mood disorders. So, things like depression, bipolar, that's really what we're going to focus on. So, let's go ahead and share our slides here and we'll get started. All right, so Chapter 7, mood disorders, here we go. And we're going to start off with that section in the book, understanding and defining mood disorders, just to kind of get an indication of what we're talking about here. So we look at the overview of mood disorders. So it turns out that the group of disorders that we're going to discuss in this session are given special names or several labels. So for example, they're often referred to as depressive disorders or affective disorders, where the primary disturbance is in affect. Sometimes they're labeled depressive neurosis. It turns out that the DSM-3, or earlier version of the DSM, an earlier version, then titled them as mood disorders, meaning a gross deviation in mood, which contain highs and lows. Both depression and or mania contribute to all of the mood disorders. So either those are in combination or in complete isolation. So it kind of depends. We're going to see some variation in that. All right, so we're going to look at major depressive episode here, which is our most commonly diagnosed and most severe depression that there is. Let's take a look at our diagnostic criteria. Person is extremely depressed mood state lasting for at least 2 weeks, but is time limited, as we discussed earlier in the course. It involves cognitive symptoms, so feelings of worthlessness, being indecisive, thoughts of suicide, being powerless, or guilt. All of that would be considered part of that. Disturbed physical functions, which seem to be really central to the disorder. So, for example, it could be altered sleep patterns where they're not sleeping right, changes in appetite, loss of energy, for example. Okay. Sometimes we see like vegetative type symptoms. So, the way they're physically functioning is disturbed in some way. Anhedonia, which is loss of interest or pleasure in usual activities that bring those things. So, for example, when we think about different activities that bring us pleasure, like good food, being around friends, sex, etc., there's a lack of pleasure in those areas. Our average duration is going to be about 4 to 9 months if it's untreated. Okay, so once again, it shows that it is time limited in most cases, but we're going to look at different versions of mood disorders. Okay, so that's what we would call a major depressive episode. Next, we turn to mania. So some mood disorders involve what we call mania, which is almost the complete opposite of what we've been discussing. So abnormally exaggerated elation, joy, or euphoria. Some people compare it to an extended orgasm, for example. So the point is it's a lot of high energy there. Episodes are accompanied by extraordinary activity. For example, it could be hyperactivity, boosts of energy, periods where they're extremely talkative or work hard, for example. A lot of them seem to be very goal directed in terms of activity and energy. Requiring little sleep or a decreased need for sleep. Grandiose plans. So in this case, sort of like an inflated self-esteem, where, just as an example, where they may spend all their money to accomplish something. often believe that they can accomplish anything. So, the sky's the limit, basically. There's no limitations here. Speech may be rapid or incoherent, which we call flight of ideas. Okay, so that's because it's due to the multiple expression of ideas or desires, if you would. Average duration is about 3 to 4 months if it's untreated. It also includes irritability, anxiety, and depression, which are often involved. Once again, it kind of depends. All right, next we go to something called a hypomanic episode, which usually, to be diagnosed, only has to last for 4 days compared to a week with the manic phase. So here, less severe version of manic episode. So it's, milder in that sense. Does not cause impairment in social or occupational functioning, but it turns out is involved in the definition of several mood disorders. So in other words, it's a milder version of the manic episode where we may not see the same levels of impairment. Okay, so next we turn to the structure of mood disorders. So we have what's called unipolar disorder, where the person experiences either depression or mania. However, mania in isolation is thought to be extremely rare, except maybe possibly the adolescent population. But in and of itself, we would say that's pretty rare. Usually they go on to develop depression eventually. Okay. Bipolar disorder, which is alterations between depression and mania. However, these can be experienced simultaneously. And so if that was the case, we would call it dysphoric manic or mixed episode, where the person is feeling manic and depression at the same time. So you're probably wondering, how does that even happen where they're sort of experiencing both? So for example, the person may feel very elated and energetic to the point where they're almost out of control in that sense, possibly where it's dangerous. And then the person could feel depressed and anxious about being out of control. So that's kind of what we mean by a mixed episode. Okay, so next we go to the important features of the major depressive episodes. So remember, it is time limited. It can last from 2 weeks to more than 9 months if untreated. So it seems to be limited in its uh, duration in that sense. The person affected differs in severity, course of the disorder, and the symptoms. So there's a lot of variability. So, for example, we have some people that may sleep very little during a depressive episode, so they can't sleep, where others may sleep too much. So it kind of depends on the specific person. Almost all depressive episodes remit on their own without treatment. Remit, okay, meaning slacken, right? So almost all depressive episodes seem to slacken on their own without treatment. Thus, it's important to determine the pattern of the person's disorder. So understanding the course of that person is important to preventing future outcomes. In other words, it allows for better prediction of the disorder, because sometimes we see people where they have depressive episodes during certain times of the year. So knowing that, it would change the treatment of that person. We'll talk more about that a little bit later. All right, so let's look at our depressive disorders here. There are several types. The symptoms themselves do differ in frequency and severity in terms of the course. For example, we're going to find that some are more chronic than others. Some are more, non-chronic, as we would say. So we're going to see some different versions or types. Okay, so this one we're going to look at here is major depressive episode, a single episode. So in this case, the person has an absence of the manic or hypomanic episodes before or during the disorder. However, one episode is pretty rare, is what we're going to find. I mean, it can happen, of course, but typically there's going to be more. So one episode, experiencing just one episode in a lifetime is extremely rare. Usually depression waxes and wanes over time, but seldom disappears completely in a person. Next, we get a major depressive episode recurrent. So in this case, they've experienced 2 or more major depressive episodes. Okay. In fact, about 35 to 85% of those with a single episode will have another. So a huge proportion of those will experience another. During the first year following an episode, there's a 20% risk of recurrence. And then during the second year, it goes up to 40%. So we're going to find that it's pretty common for people to have more than one episode. These have to be separated by at least 2 months or 2 consecutive months, meaning during which the individual is not depressed. So it shows that they are separate episodes based on that amount of time. Typically, people with this description usually have a family history of depression, which seems to be different from a single episode of depression. All right, let's look at our statistics for major depression. Usually have had at least 4 episodes in a lifetime. That varies from 4 to about 7, okay? But our median duration is about 4 to 5 months for those, okay? So once again, most people have had at least 4, can be more, and usually they last about 4 to 5 months on average. Remember, that's the median value. Our average age of onset is about 30. So we're going to find that typically the person is about 30 years of age. In fact, the risk of this is really low until the early teens, where we do see some spikes there. Okay, but once again, we're going to find that the average, if we average it all out, 30 years of age, but also to keep in mind that we do have a cluster of depression 55 and older. So a lot of times it does happen at older ages. So we see some variability here. But once again, if we average that out, about 30. The length of the depressive episode is variable. So it could be 2 weeks to several years. So the typical duration, if we look at the typical duration of the first episode specifically, it's about 2 to 9 months if it's untreated. So once again, we see some variability with that. All right, so next we go to something called dysthymia, which is our classic term. The DSM currently calls it persistent depression, but those are synonymous, if you would. But in terms of the class, we'll go with persistent depression. Very similar to major depression, as far as the symptoms. However, symptoms are milder and remain unchanged over longer periods of time. So once again, dysthymia is a persistent form of depression with fewer symptoms and milder symptoms. So keep in mind, this could last 20, 30 years. And we've had cases where it's longer. Diagnostic criteria is depressed mood that lasts for at least 2 years with no breaks. Client must not be symptom-free for more than 2 months at a time. They may also experience a major depressive episode at some point as well. Our mean age of onset for persistent depression is in the early 20s. So notice a little bit different. If it does happen earlier, it tends to be more chronic, have poorer prognosis, and more likely to run in the family. So once again, if it occurs earlier in the person. It also would indicate a higher risk for things like personality disorders, which we'll cover in later chapters. The median duration is about 5 years for adults and 4 years for children. Unfortunately, they have a high likelihood of committing suicide compared to, say, major depression disorder. So this one seems to be more chronic compared to the other types, but also we're finding it's more resistant to treatment. So this one's serious because it lasts longer. There's a high probability of suicide, and they often do not respond to treatment as well. Okay, moving on. As we said, there's quite a few here. We have something called double depression. So this refers to both major depressive episodes and persistent depressive disorder as well. Typically, they're going to have few depressive symptoms at first, usually at an early age, then one or more major depressive episodes occur later, and then possibly go back to the original symptoms. This one's kind of alarming because it's often associated with severe psychopathology and a problematic future course when we compare it to some of our other ones. It may last a long time, or the person may suffer a relapse. So in other words, they may get treatment and get better, but then relapse at a different point in time. In terms of the prevalence of this one, it turns out that it's pretty common, especially among the depressed population in general. For example, about 79% of those with persistent depression report a major depressive episode at some point in their life. So 79%, according to that study. Often start off with being severely depressed, recover, but remain severely depressed after 10 years. Okay, so that's double depression there. Next, we turn to our bipolar disorders. Okay, so we're going to look at a few of these. So let's just kind of introduce this one a little bit more. So the tendency of manic episodes to alternate with major depressive episodes. So in other words, it's often like an emotional roller coaster with this person where there's high peaks of elation and activity to the bottom depths of despair. So that's obviously why we refer to it as bipolar, meaning almost like polar opposites at time in that person. Bipolar disorders parallel depressive disorders. So for example, the mania may occur only once or repeatedly. So just like our depressive episodes that we've talked about. Okay, and there's basically two types that we're going to cover. So two types of this disorder. So our first one is called bipolar 1 disorder. So there's an alternation of full manic episodes and depressive episodes. For two manic episodes, it must be a full 2 months of symptom-free behavior to be considered two different episodes. What's interesting about this one is that they often deny they have a problem, especially during the manic phase. So maybe a little resistant to going to get treatment. We find cases where they spend lots and lots of money, they sleep little, make foolish decisions, maybe so wrapped up in their mania or manic episode to actually realize what's happening. Our average age of onset, as you can see, is about 15 to 18, but can begin in childhood. So we do see sometimes it occurs in childhood. However, very rare after 40 for both types that we're going to talk about. Tends to be chronic in nature. So in some cases, the person may alternate indefinitely. So very chronic. Unfortunately, suicide is a common consequence of this disorder. As you can imagine, typically would occur during the depressive episode or phase, if you would. So our estimates of suicide range from 12 to 48% over a lifetime. And that is 20 times higher compared to people who do not have bipolar. Typically, the ones that commit suicide are usually male and have a first degree relative who has committed suicide. So we often see this, family pattern, but also being male. Okay, bipolar type 2 is our second type of bipolar. So major depressive episodes that alternate with hypomania, as we described earlier. So remember, this is a milder version of that where there's no impairment in social or occupational functioning. In other words, they're not experiencing the full-blown manic episodes. Average age of onset is about 19 to 22 years of age. Okay, so like type 1, it can occur in childhood. Note that this is somewhat younger than the average age of onset for major depression, which we said is about 30. So bipolar in general the onset of that seems to be younger. About a third of bipolar cases do begin in adolescence. Okay. A way I would describe someone with bipolar 2 is that they sort of seem to be the life of the party, but not as dangerous to themselves or others like we would see with bipolar 1. Only 10 to 25% of cases actually progress to full bipolar type 1. This also tends to be chronic as well, and thus needs to be treated because obviously it's connected with some major problems. Okay. Typically, treatment is going to be medication, but it kind of depends. And of course, the book discusses that. So that leads us to our next one, cyclothymic disorder, which is very similar to persistent depression, as we described earlier. So this would be a more chronic version of bipolar, where in this case, in most cases, it's going to be a lifelong problem, so very chronic. The manic and depressive episodes are less severe in nature. So in other words, they're both mild. Tend to remain in either a manic or depressive mood state for several years, with few periods of what we would describe as being neutral or in between, if you would. To be diagnosed with this, the pattern must last for at least 2 years. If they're a child or an adolescent, the criteria is a little bit different. It's about 1 year. Okay. So our criteria the person has not been without symptoms for more than 2 months. Average onset is about 12 to 14, which is younger than the traditional version of bipolar, as we discussed earlier. However, it's often not recognized because remember, it could be a really young person in this case. It may be just described as being moody, explosive, or high strung. So sometimes it's missed. But if we look at the research and the numbers, it seems to be about 12 to 14. It does tend to be chronic and lifelong. About a third of these individuals develop into full-blown bipolar disorder. And the studies are showing that most of them are female. So according to research, it's about 60%. Okay, so 60% female. and would show an increased risk for developing both bipolar 1 or bipolar 2. Okay, so those were different disorders. Now we're going to take it to the next step. We're going to look at some additional defining criteria for mood disorders. Which we know as specifiers, and we'll look specifically at those. So these are other symptoms that may accompany a mood disorder, and they're important because they help us devise a treatment. So they're helpful, useful in treatment, and many, or they may, excuse me, may or may not occur. So it kind of depends. There are two types. Those that describe the most recent episode of depression or mania, and then those that describe its course or temporal pattern. So it kind of depends. As we go through them, you'll see what I mean, that it may refer to the most recent episode the person has experienced or explaining how it sort of unfolds and develops over time. Okay, so let's take a look at these. So these are our basic specifiers of depressive episodes. The first one is known as atypical features specifier. And the way I want you to think of this one, they are unexpected symptoms. So this applies to depression as well as persistent depression, but not necessarily mania. So in this case, they're doing something that's sort of unexpected, like oversleeping, overeating. It could be that they've gained weight or they're showing anxiety, for example. They're showing pleasure. Remember, we said that one of the things with depressive episode is anhedonia. So they may be able to experience pleasure depending on the person once again. So that differs for most depressed people. This specifier or these specifiers are associated with an earlier age of onset, and a greater percentage of them are women, more severe symptoms, and are more at risk for suicide. Okay, so once again, they're important to note. By the way, when we see this, it could be that they actually have another disorder, such as substance abuse or alcohol abuse, as an example. Okay, so the next one is the melancholic features specifier. This applies only if the full criteria for a major depressive episode has been met, and it includes some of our more severe symptoms. So, for example, loss of sex drive, excessive guilt would be an example, waking up too early, anhedonia would be classified in this one as well. And usually, when these are present, it signifies a more severe type of depressive episode. Okay, the next one we're going to look at is the catatonic features specifier. And essentially, here it's problems with movement. So the person is showing, the symptoms of a mood disorder, but they're also showing issues with their physical movement. This applies to major depressive episodes and manic episodes, by the way. It's thought to be extremely rare, so this is one of our more rare specifiers, especially in manic cases. So in some cases, it could involve total absence of movement, almost like the person's in a stuporous state, or it could also show excessive movement. So it kind of depends, where it's almost like they've become a statue and they're almost like frozen in time in a sense, or it could be just excessive movement. The point is that the movement seems to be, dysfunctional. So their arms and legs may remain rigid, like a mannequin almost, and can remain in the position that you place them. So you can actually, in some cases, move them and they'll hold that position. So kind of a bizarre one, but also a very rare one. Psychotic features specifier, another rare specifier in the depressive disorders or the mood disorders. So this applies where the psychotic symptoms are experienced during a major or manic episode. These ones are alarming because they often show a poor response to treatment and higher risk of impairment. So this could include things like hallucinating. So maybe they're experiencing hallucinations, or they have delusions or unfounded beliefs. So they could like hear voices or believe something is happening when it is not. So for example, they may think that their body is rotting from the inside out, but from a medical standpoint, there's no evidence to support that. Hallucinations and delusions may be what we call mood congruent, the symptom content directly related to their depressed mood, but it could also be mood incongruent, where it's not necessarily tied to that. This is very serious because it often, we see in some cases, can progress to full-blown schizophrenia. So once again, a lot of those symptoms seem to overlap with schizophrenia and could be an indication that the person is progressing in that direction. Okay, so next we go to the peripartum onset specifier, so a completely different set of symptoms or specifiers, if you would. So this applies to major and manic episodes. So here it's characterized by severe manic or depressive episodes that are psychotic in nature that first occur during what we call the peripartum period of pregnancy. So that is from the end of pregnancy to about 6 weeks after childbirth. Now keep in mind, this does not just apply to mothers, it applies to mothers and fathers. So contrary to popular belief, it's actually both genders. So it could occur in either gender is what I'm saying. It's important to note because the person could be completely psychotic and could endanger their child. So that's obviously we'd want to, notice that and take note of that. Okay, so 13 to 19% of women giving birth meet the criteria for major depression and have a greater incidence found after birth. However, this is not applied to mild depressive episodes following childbirth, immediately following childbirth, like 1 to 5 days after the child is born, because baby blues, as it's currently known, is considered to be a normal response to childbirth. So we would consider that, but if it's progressing onto that, and like we said, in some cases, 6 weeks later, and they seem pretty severe in nature, this one we would give this specifier. Okay, next we go to the anxious distress specifier, which is the presence and severity of anxiety in the person. But in this case, the person may or may not actually meet the criteria for an anxiety disorder, as we've described in earlier sessions. Okay, so they're showing anxiety as well as depression. This is important to note because suicide thoughts and actions often increase under this specifier. So in other words, it often is connected to suicide or can be, and often predicts poor outcome to treatment. So we'd want to know that and sort of treat that. Mixed features specifier. Persons had at least 3 symptoms of mania and applies to major depression and persistent depression. So in other words, they're showing both, where they're showing the major depressive episode, but also mania, as we described early in the lecture. Okay, and then finally, the seasonal pattern specifier. So this applies to recurrent major depression and bipolar during certain seasons. So we said that sometimes it may happen under certain circumstances or times of the year. So this is applicable to something called SAD, which is seasonal affective disorder, where the person may show symptoms only during certain times of the year. So this must occur for at least 2 years with no evidence of non-seasonal major depressive episodes. So just to kind of speak to this a little bit more, the SAD, the seasonal affective disorder, is where the person typically, usually we see it in northern latitudes where the person becomes depressed during certain times of the year. Typically, it's winter, and we think it may be due to problems with melatonin during winter and lack of sunlight. So a lot of times, phototherapy is instigated with that one. Okay, so next we're going to turn to specifiers describing the course of mood disorders. We have a longitudinal course specifier, or meaning a long-term analysis of what that's referring to. So in this case, we want to know, does the person have a past episode of depression or mania, or did they recover fully from past episodes, for example? So what's the long-term outlook of what's going on? For example, was the persistent depression present before the major depressive episode? Did the person show cyclothymia before bipolar? So if so, this decreases the chance of recovery and increases the length of treatment. So once again, those are important to know. Next, we go to rapid cycling pattern, which applies only to bipolar 1 and 2. So it turns out about 20 to 50% of people with bipolar experience this. So this one is used when the person has had at least 4 manic or depressive episodes within a period of a year. In other words, it shows that they're moving back and forth quickly between episodes. This would be considered to be a more severe form of bipolar that does not respond well to treatment. So once again, it's important for the psychologist to know that. It's associated with higher rates of suicide, so it's very serious, as well as more severe episodes of depression. So once again, we'd want to note that. In this particular case, they may give alternative drug treatments that are used with this, which could include anticonvulsants, mood stabilizers, rather than, say, antidepressants. We know that a lot of the cases are female, so the research is sort of pointing to that. So in fact, the rates are higher than other forms of bipolar, where bipolar in general seems to be pretty equal between male and female, but this one seems to be we see more female cases. Rapid cycling tends to increase in frequency over time to the point where there's no break in between. So once again, it seems to kind of get worse as they go. All right, next we go to the seasonal pattern specifier. So we've already alluded to this with SAD, seasonal affective disorder. This applies to bipolar and recurrent major depression. So it indicates if the episodes are occurring during certain seasons. Once again, typically it's going to be winter. All right, so we call that seasonal affective disorder, where the person may display excessive sleep and weight gain. We think it's related to their circadian rhythm and seasonal changes, but also involving the increased production of melatonin. Melatonin, the Dracula hormone, as it's known, is what makes you drowsy when it's dark. Okay. So if they're living, say, like in Alaska, there's not a lot of sunlight, more melatonin would be produced, and it may change their sleeping patterns, but also change the state of mood. So that's one thing we would kind of look at. So like we said before, it's common that they would give them like phototherapy in the morning, which seems to be pretty effective. That's also really effective when we combine it with cognitive behavioral therapy. So that may help to kind of even things out, if you would, and help the person. And like we said, we typically see that happen more in the northern latitudes. Okay, so if you're more a visual person, this just kind of shows the mood, how like January, February, when it's winter, they're feeling rock bottom, and then spring comes and summer, they feel basically normal, and then here comes, fall and winter again. And so it's like this cycle every year. So that obviously that's important to note because it's specifically related to, potentially melatonin levels, sunlight levels, etc. Okay, so next we're going to look at the prevalence of mood disorders based on research. When we compare mood disorders to other disorders, they seem pretty common. In fact, they're very common. So, some people refer to it as the common cold of psychopathology. So definitely more common than some of the disorders we talk about in the class. Okay, so for major depressive episode, 20% of people will experience this in their lifetime and 6% in the past year. So that's for major depression. By the way, with major depression, the risk is low until early teens. Persistent depression, it's about 3.5%, and that's both lifetime and the past year. So not as common. Bipolar, what the studies are showing, it's about 2.4% of lifetime and then 1.5% in the past year. Okay. So note that bipolar is rarer than, say, major depression. Also note that dysthymia and bipolar are more chronic. So that may be, related to the prevalence of those. Women are twice as likely to have mood disorders except for bipolar. So that's more specifically, that's true of major depression and persistent depression. In bipolar, we find that it's about equal according to the studies. However, you could also argue that women experience more anxiety, rapid cycling, and more likely to be in the depressive phase compared to men, and more in the cyclothymia. Okay, so next we turn to the prevalence in children and adults. So depressive disorders occur less often in pre-pubertal children. Sorry, pre-puberty is what I'm trying to say, but does rise in adolescence. However, many children experience depression, but not enough to actually diagnose them as far as the severity and the duration of it. Sex ratio in childhood is about 50-50. This will change and lean more to females in adolescence. Bipolar rates are comparable to adult rates in children and adolescents, so about 1%, and that has increased in past years. Some people think this is due to the expanding or broadening of the diagnostic criteria for children to show the developmental nature of bipolar disorder, and possibly done for insurance reasons. There's some difference of opinion on that. Okay, prevalence in older adults. Some studies are showing that about half the rate when compared to the general population. Remember, so here we're saying it's 65 and up. However, can be as high as 42% in nursing homes, and 42% of those in nursing homes may experience major depressive episodes. Okay, so we'll go ahead and stop there for our lecture. Thanks for watching it, and I hope that kind of enlightens you on the subject of mood disorder. So please move on to the next section in the class.